This is the first in a series of lectures on the imaging of cystic neck masses. There are many different ways that you could categorize cystic neck masses, but the scheme that I like is congenital abnormalities, developmental abnormalities, which you aren't born with but may come early in life, lymph nodes that have become cystic, and then the grab bag of other. Among congenital cystic neck masses, the most common is the thyroglossal duct cyst. There are also lymphatic malformations, branchial cleft cysts, and then the less common lesions like dermoids, thymic cysts, and a variety of duplication cysts. We'll go through all of these. First, let's talk about thyroglossal duct cysts. They are very common. In fact, they are the most common congenital neck mass. They appear in the anterior neck near the midline, and they're usually pretty clear clinically when they arise. In order to understand the different potential locations of thyroglossal duct cysts, you need to understand the embryology of the thyroglossal duct. In adult life, the thyroid gland sits down at the base of the neck, but interestingly, it doesn't develop there in fetal life. It develops first in the tongue, right at the foramen cecum, which differentiates the oral tongue from the base of tongue. During fetal life, the thyroid gland migrates through the tongue and then down the front of the neck until it reaches its normal adult location. As it's coming down, it incorporates into the developing hyoid bone, and when the hyoid rotates to its normal position, it gets wrapped up in with the hyoid bone. At about that same time, it splits from a median onlog into two-sided onlogin, and that will become the two lobes of the thyroid, and then those two onlogin separately descend down the rest of the front of the neck. Thyroglossal duct cysts can occur anywhere along this pathway. They're most commonly infrahyoid, but they can occur up in the tongue, in the middle of the tongue, often wrapped up into the hyoid bone, or down the front of the neck. Interestingly, once they're below the level of the hyoid bone, they tend to be just off midline, whereas above the hyoid bone, they tend to be right in midline because this is where it splits into its two lobes. Just to reemphasize that, superhyoid thyroglossal duct cysts can be in the tongue and they tend to be midline, whereas infrahyoid thyroglossal duct cysts tend to be just off midline, not far, just off midline. Infrahyoid thyroglossal duct cysts are intimately related to the strap muscles. This is a really important imaging feature, and it differentiates thyroglossal duct cysts from some of the other cystic masses that we're going to encounter. So when you see an infrahyoid thyroglossal duct cyst, look for the intimate relationship with the strap muscles. Occasionally, a thyroglossal duct cyst will degrade into thyroglossal duct carcinoma. This occurs in less than 1% of these lesions. Thyroglossal duct carcinomas are characterized by mural nodularity, nodules in the wall of the cyst, and by calcifications, which are often seen in other forms of thyroglossal or thyroid cancer. This is the classic radiologic appearance of an infrahyoid thyroglossal duct cyst. Note that the center of the cyst is just off midline because it's infrahyoid, and look at its relationship to the strap muscle. The strap muscle is coming up and clawing, forming a claw sign around the edge of the cyst. This intimate relationship between the cyst and the strap muscles critical for this diagnosis. This is a very simple cyst with nice smooth walls. More complex cysts will arise with repeat infections. Infections are in fact how these usually come to clinical attention. Here's the same look on MRI. Here is a thyroglossal duct cyst just off midline in the anterior neck. Note how the strap muscle comes up and claws around the cyst, right? That intimate relationship with the strap muscle. This cyst is bright on this T1 weighted image. That tells us that there is proteinaceous debris within the cyst itself, presumably from recurrent infections. Here's the T2 on that same patient, and you can see that there's a lot more going on beyond just the cyst itself. All of this additional inflammation in the strap muscles, even extending into the larynx, this is indicative of acute infection of this cyst. Of course, this patient will have to be defervesced before surgery is pursued. Here is another potential location for thyroglossal duct cysts that is really important to remember. This multilobulated cyst is sitting right at the foramen cecum, right between the oral tongue and the base of tongue. This is a classic location because this is where the thyroid initially forms. Another important concept to take away when you see thyroglossal duct cyst in this location is a reminder that the thyroglossal duct, when it fails to involute, as it normally does, will leave a tract going all the way up into the tongue. In order to surgically treat these patients, the entire thyroglossal duct cyst, from the site of the cyst all the way up to the base of tongue, needs to be resected. This is called a cistrunk procedure, and it is the definitive treatment for thyroglossal duct cyst. Here's another example of a thyroglossal duct cyst, infrahyoid, off midline, right in the middle of the strap muscle here. Classic location for an infrahyoid thyroglossal duct cyst. Here's an example of a thyroglossal duct cyst that appeared within the larynx. This is not that uncommon. Remember how the thyroglossal duct gets wrapped up into the hyoid muscle, the hyoid bone, during fetal development. This means that you often get thyroglossal duct cysts that wrap around the hyoid bone and even end up intralaryngeal. So that's not unusual. But there's something else that's really important to observe in this particular case. This patient has a nodule at the periphery of this thyroglossal duct cyst embedded within the strap muscles. And this nodule has calcifications within it. These are the signs of thyroglossal duct carcinoma. Thyroglossal duct carcinoma doesn't tend to occur in children. It tends to occur with the same demographic characteristics that thyroid cancer has, particularly papillary thyroid carcinoma has in the adult population. So we're looking for teen to young adult, and more commonly in women when we're looking for thyroglossal duct carcinoma. Let's turn now to lymphatic malformations. Lymphatic malformations have some historical terms like cystic hygroma and lymphangioma, but these have been abandoned for the more precise and accurate term lymphatic malformation. Lymphatic malformations are fairly common. They can arise anywhere in the neck, and in fact anywhere else in the body too, but frequently in the neck. The key finding that will distinguish lymphatic malformations from other cystic neck masses is their transspatial spread. Lymphatic malformations don't care at all about the cervical fascia, and so they will spread from one cervical space to another cervical space. If you need a review on cervical spaces, there are lectures in this series on the normal anatomy of the neck. Lymphatic malformations often come in combination with venous malformations. They occur on a spectrum from purely lymphatic to purely venous and anything in between. Sometimes you see 50-50 venous and the other half lymphatic. So sometimes it's easier to use the more generic term venal lymphatic malformation if you're not sure what percentage is venous and what percentage is lymphatic. Here's an example of a lymphatic malformation. How do we know that this is a lymphatic malformation? Well, most of this thin-walled cystic mass, there's really no perceptible wall. Thin-walled cystic mass is in the submandibular space. You can see it's displaced the submandibular gland that's visible on either side. But that's not all. It also extends forward and wraps around the mandible. That is a violation of the fascial spaces for it to wrap like this. And The lymphatic malformations are not afraid to do that. So it is this spread, this intercalation between the jaw and the muscles in the floor of mouth. That's what gives this away as a lymphatic malformation. Here's another example of a lymphatic malformation. Yes, most of this mass with an imperceptible wall is sitting in the posterior triangle, but look at it intercalate back between the muscles of the posterior neck, this infiltrative pattern. It's really benign, but this infiltration of this benign mass is what marks this as a lymphatic malformation. It doesn't care about wrapping around vessels. It doesn't care about wrapping around muscles. That's what marks it as a lymphatic malformation. It doesn't care about encapsulating the fat. Now, I've been talking about this as having an imperceptible wall. That depends on not having a lot of previous infections. If a lymphatic malformation has numerous previous infections, it can have a thicker wall, it can have visible enhancing septations, it can look really nasty, but that's just a result of chronic infection. Now, you might look at this mass in the base of the tongue and say, this is a very well-confined mass. It's got a nice, well-defined rim. Why should I ever suspect that this is a lymphatic malformation? And the answer is, look more carefully. Here is another aspect of the lesion that is infiltrating into the muscles in the floor of mouth. All of this is additional lymphatic malformation in addition to this rounded component. So that's how you can get to the exact diagnosis. Now, lymphangiomas come in two forms, macrocystic and microcystic, and the term cystic hygroma, which is now outdated, refers specifically to the macrocystic form of lymphatic malformation. The macrocystic form will often have debris within a larger cyst instead of small, tiny cysts that are all clustered together, and that debris can form a layer. So this is another finding that might indicate lymphatic malformation, specifically the macrocystic form of lymphatic malformation, previously called cystic hygroma. Let's turn our attention now to the third entity in the congenital category, the branchial cleft cyst. This lesion is far more common on tests and quizzes and lectures than it is in real life, but we'll give it its due because this is that kind of lecture. First off, let's talk about some terminology. It is not a brachial cleft cyst, it is a branchial cleft cyst. The word brachial refers to the arm. The word branchial refers to gills and reflects the embryological origin of these lesions. Branchial cleft cysts are diagnosed by location, location, location. Unlike lymphatic malformations, which can occur anywhere, branchial cleft cysts always occur in very predictable locations, so you can usually suggest a specific diagnosis. In order to understand these locations, once again, it's useful to go back and review the embryology of the neck. This is a microscopic view of an early human fetus. You can see in the region of the neck several discrete arches, the branchial arches, that will develop into critical structures of the face and neck. In between these are clefts, the branchial clefts. For the most part, they involute, except for the first branchial cleft that becomes the ear. The other branchial clefts will involute. But sometimes a small cyst gets left behind, a branchial remnant. Now, in truth, these branchial clefts extend all the way from the pharyngeal surface internally to the skin on the outside. So you can end up with a fistula that maintains that entire communication from the pharynx to the skin, or you can end up with a sinus tract that just goes partway, or you can end up with a cyst that's just in the middle. Some of the key concepts, reviewing what we've already talked about. The extent of a branchial cleft anomaly can be a complete fistula between the skin and the pharynx, can be a sinus tract extending from one of those two surfaces and dead ending, or can be a cyst that meets neither the pharyngeal surface or the skin surface and just forms internally. This is by far the most common. Again, location, location, location. That is what's going to tell us that it's a branchial cleft anomaly, and these are rare, rare, rare. They're much less common than you might imagine from how often radiologists talk about them. Let's talk a little bit more about terminology because I think this is something that people frequently get wrong. When we refer to the branchial cleft cysts, we refer to the branchial clefts that they arose from, and those are enumerated first, second, third, and fourth. So the first branchial cleft gives rise to first branchial cleft cyst. People like to call a third branchial cleft cyst a type 3 branchial cleft cyst. There's no such thing, just a third branchial cleft cyst. Now, it is true that each of these gets broken down into different types. Most commonly, the first branchial cleft cyst gets divided into type 1 and type 2, which we'll talk about. There are some divisions similarly for second branchial cleft cyst, type 1, type 2, type 3, and type 4, but they are less commonly utilized. Let's talk first about the most common of the branchial cleft cysts. This is the second branchial cleft cyst. The most common location of the second branchial cleft cyst is just anteromedial to the sternocleidomastoid muscle at the level of the hyoid bone. A branchial cleft cyst usually has no discernible wall, although repeat infections can make it more complex with septations and a thick wall. It is this location that we are looking for. Be a little bit careful because lymph nodes can occur in this location too, but if you see a simple cystic mass with no wall in this location, it is likely a branchial cleft anomaly, particularly if it arises in a teenager or child. But that's not the only place that we can get second branchial cleft cysts. The second most common location for a second branchial cleft cyst is in the parapharyngeal fat. Now, normally when we're talking about the parapharyngeal fat, we're talking about all the different spaces around it. It's a marker for our differential diagnosis to help us figure out where the lesion came from based on how it displaces the parapharyngeal fat. A lot more on that in the anatomy of the neck lecture. But there are a few lesions that can arise within the parapharyngeal fat and completely replace that parapharyngeal fat. One of those lesions is a branchial cleft cyst, a second branchial cleft cyst. Now, how did it get here? The truth is that a complete fistula of the branchial cleft runs from the tonsil down through the parapharyngeal fat and then out laterally through the side of the neck at the level of the hyoid bone. So that's why you see it down there in front of the sternocleidomastoid muscle, but you can also see it here up near the tonsil. Second most common location of a second branchial cleft cyst. All right, now let's turn our attention to first branchial cleft cysts. There are type 1 and type 2 first branchial cleft cysts. When you see a type 1 branchial cleft cyst, you can think of it as a duplication of the external auditory canal, because it kind of is that. It's a duplication of the external auditory canal. It usually will have communication either to the skin surface or to the surface of the external auditory canal, and a little pit will be visible clinically inside the external auditory canal. So we expect a first branchial cleft cyst type 1 to be right near the external auditory canal. That's its key imaging location. The type 2 first branchial cleft cyst occurs more inferiorly. It occurs at the level of the angle of the mandible. So this is in the subcutaneous tissues at the level of the mandible, and that's where you will find a type 2 first branchial cleft cyst, and you can see infiltration all the way around this mass because it happens to be acutely infected at the time of imaging. Now we're getting to the lower branchial cleft cyst, the third and fourth branchial cleft cyst. A third branchial cleft cyst is usually deep to the sternocleidomastoid muscle and lower down in the neck at the level of the larynx or lower. Right? These can be difficult to distinguish from other cystic masses in the neck. The key to this diagnosis is that there is usually still a communication to the piriform sinus. The third branchial cleft fistula arises in the lateral aspect of the piriform sinus and extends down through the neck to emerge in the lower neck, skin of the lower neck. And the third branchial cleft cysts occur along that tract in this approximate location. Fourth branchial clefts usually appear as fistulas. It's the only one that is more commonly a fistula than a cyst. Now, the fourth branchial cleft fistula arises not from the side of the piriform sinus like the third branchial cleft does, but from the tip of the piriform sinus, and it extends down and then out the side of the neck. You can often make this diagnosis on an esophagram by watching contrast flow through the open fistula and emerge through the side of the neck. Of course, a cyst can form anywhere along this tract, but the full fistula is more common for the fourth branchial cleft. Here's a picture that shows a mass inside the thyroid gland. And you might be asking yourself, why are we talking about thyroid lesions in the middle of a lecture about branchial cleft cysts? When you see an abscess of the thyroid gland, you must suggest that there could be an underlying branchial cleft anomaly. The third and fourth branchial clefts, as they travel down through the neck, go adjacent or within the thyroid gland. There are very few other reasons to get an abscess of the thyroid gland. It's very rare outside of these anomalies. So when you see an abscess, with air, an abscess of the thyroid gland, you have to suggest a lower branchial cleft fistula. And endoscopy or a swallow study should be performed to seek that pit within the piriform sinus. This ends part 1 of the lecture series on cystic neck masses.